week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
So our presenter today is Madeline Burling. Madeline is a PGY2 emergency medicine resident at North Kansas City Hospital. She's going to be talking to us today about sedative dose for rapid sequence intubation and post-intubation hypotension, and looking at the association between those factors.
Thank you for that introduction. Like she said, my name is Madeline Burling. I'm the PGY2 emergency medicine pharmacy resident at North Kansas City Hospital. And today I'm really excited to talk to you about an article entitled Sedative Dose for Rapid Sequence Intubation and Post-Intubation Hypotension. Is there an association? So as she also mentioned earlier, this does kind of have a theme. We will be talking more about ketamine and etomidate as we go through and just kind of determining whether dose of those intubation induction agents really change our incidence of hypotension. By the end of the presentation, I hope that you'll be able to articulate background regarding sedation-related hypotension following intubation and evaluate this article, which examines the incidence of dose-related post-intubation hypotension. We'll start off with a little bit of background here regarding RSI. As we know, there are 7 Ps of RSI, or rapid sequence intubation. The first is preparation. We want to gather our equipment, gather the weight, dose, and the induction or paralysis agent that we'll be using. Pre-oxygenation is in order to achieve a high level of oxygenation saturation to protect the patient during the inevitable drop that occurs during intubation. Formerly known as pre-treatment, pre-intubation optimization is really looking at the full picture, looking at the patient, trying to identify and mitigate cardiopulmonary vulnerability or risk factors, things like that. We're going to try to stabilize hemodynamics and consider contingency plans in the event of an unsuccessful or high-risk intubation. The next is what we'll focus most of our time on today, which is paralysis with induction. This is use of our neuromuscular blockers or our induction sedation agents, often used in tandem. Next is positioning. The intubating provider will position the patient's head, neck, and jaw in a way that allows for a successful intubation. Next is placement with proof. So this is the placement of the endotracheal tube with the proof of placement. This is often capnography, bilateral breath sounds, or a chest X-ray, just to make sure that we know where we put the tube and ensure that it's in the right position. The final step is post-intubation management. This is our post-intubation sedation, hemodynamic management, things like that. So this should be mostly reviewed for all of us, but this is where we'll be spending most of our time today. As I said, we'll be talking about induction sedation specifically. So this is not post-intubation management, this is not post-intubation sedation, but really induction sedation. And again, a little bit of crossover here with Jessica's presentation. We'll start off by talking about etomidate. So it is a short-acting anesthetic, onset of action 30 to 60 seconds, duration around 5 minutes, and it increases the affinity of GABA to its receptor. As Jessica mentioned, this is a 0.3 milligram per kilogram dose for intubation is what we usually do. And we'll see if we need to be decreasing that for the purpose of post-intubation hypotension. It is widely seen, as we've done this, literature review right before this presentation, it is seen to be pretty hemodynamically neutral. And actually the SCCM guidelines just from today even recommended that there's no difference between etomidate and other induction agents in mortality or incidence of hypotension. And this is a moderate level of evidence. So for all of those pieces of literature that we've just gone over, that's kind of the culmination of that. And we're showing that this is known to be pretty hemodynamically neutral. However, it does have some adverse effects that were previously mentioned. This myoclonic unilateral limb jerking can mimic seizures. It can have some adrenal suppression. So this is along the hypothalamic pituitary adrenal axis. And even one bolus is said to be able to inhibit cortisol production. This could potentially, theoretically, cause hemodynamic instability. What it basically does is it could increase our stress response. Stress response is oftentimes in charge of keeping us hemodynamically regulated, making sure that our blood pressure is appropriately responding to whatever situation or disease state we have, and things like that. So by inhibiting that, theoretically, we could be reducing that and causing hypotension that way. As Jessica mentioned, this has mostly been debunked. However, it still does happen, but this is why we don't do continuous infusions. This is why this isn't our post-intubation sedation, but it is seen to be very largely safe, not clinically relevant, especially in these like induction agent bolus doses. This is just kind of reminding us where it acts on the GABA receptors. Next, we'll talk about ketamine, and this is also a fast onset anesthetic. It can happen within 30 seconds and it lasts around 10 minutes. It is an NMDA receptor antagonist. It blocks glutamate. So whereas etomidate focuses more on increasing our inhibitory response, ketamine kind of decreases our excitatory response. So this is usually a dose of 1 to 2 milligram per kilogram IV for intubation. And it is also seen to be hemodynamically neutral in many ways, especially more than something like propofol or midazolam. It can have some adverse effects too, though. It does have emergence phenomenon up to 12%, and then nystagmus or diplopia. However, these are things that happen when they're coming off of the anesthesia of ketamine. So this isn't typically things that we'll see when we are intubating someone with that, because typically someone who's being induced with ketamine, they will have different types of sedation for the remainder of their intubation. So these aren't the reactions that we're really worried about, but there are other things that we can worry about during intubation with ketamine. It has a risk for laryngospasm, which is basically when the vocal cords tense up, they contract, they can kind of seize or spasm, and this can make intubation a little bit more difficult. This is rare. I think it's a lot scarier than it is clinically relevant. It usually lasts less than 60 seconds, just to be aware that that is something else that can happen with ketamine. And then it can have hemodynamic effects. So it can have both increased and decreased blood pressure. So just going over a couple different studies, one that showed that it was way less incidence of hypotension than etomidate, the other that showed that it was more, and then kind of overall her article showed that there really wasn't a difference in that between the two. However, it does have to do with sympathetic stimulation. So it stimulates our body to release more catecholamines. And so this is something that increases our blood pressure and our heart rate. But it kind of depends on their state. So if they're already catecholamine deficient, the stimulation that would normally cause the blood pressure to increase can no longer stimulate any more catecholamines because the patient is deficient. So this actually makes the blood pressure drop a little bit. So it's a little bit less reliable, and it's not as backed up in every single literature that it does one thing or the other. And it might not even be the same in every patient. So I agree with, Jessica's summary that the point is to look at the patient and look at what they might be dealing with there. So just some background with this. It is widely known in multiple studies, kind of listed there at the bottom, that post-intubation hypotension is associated with increased morbidity and mortality. This has been shown time and time again. There are a few articles that looked at specific risk factors. So this includes shock index, which is defined as heart rate over systolic blood pressure, chronic renal disease, intubation for renal failure or respiratory failure specifically, and then older age. So these are some things that can increase the risk of post-intubation hypotension, which is associated with increased morbidity and mortality. There's a natural response to this by many clinicians that say, okay, then we need to decrease our dose of induction agent, as well as post-intubation sedation and things like that. But by decreasing our sedation, we end up having this concern or this increased risk for awareness with paralysis. So we use paralytics or neuromuscular blockers in many intubations. And oftentimes the problem is that we don't properly sedate, and up to 3% of the time, patients who received a neuromuscular blocker are actually aware of what's happening to them under this paralysis. So they know what's happening, they can feel pain, and they can even sometimes remember it. And this is how this study looked at that. The ED Awareness did a lot of patient surveys and just kind of talked to people about whether they could remember certain pain or certain procedures happening while they were intubated. And this is kind of has raised this concern of, we really want to make sure that this isn't happening. It's extremely traumatic for patients. They end up having PTSD when it comes to healthcare and things like that, which is reasonable. We can only imagine how terrifying it is to be paralyzed and having these things done to you. So when we're talking about this post-intubation hypotension, yes, we want to avoid it because of the increased morbidity and mortality. However, increasing the induction dose we just want to be really sure that that's the right thing to do on the off chance that it is increasing this awareness with paralysis. So that's what this study is going to talk about. We're looking at the induction dose of sedation agents and their relation to post-intubation hypotension. The objective here was to determine whether the post-intubation hypotension was associated with ketamine or etomidate was dose dependent. So just to kind of clarify here, we're not comparing etomidate with ketamine. We're actually looking at both of them separately, kind of within themselves, and whether the dose changes between or within the agents were associated with more or less hypotension. They just happened to look at two agents separately. So keep that in mind. It was an observational national study based on the data from the National Emergency Airway Registry, which we'll talk about on the next slide. The intervention, basically, they recorded any ketamine and etomidate doses at the time of intubation and observed the incidence of hypotension within those 15 minutes following intubation. The National Emergency Airway Registry is a multi-center prospective emergency medicine-led database. So basically, providers who are working in an emergency medicine setting can sign up for this registry and document their experiences with this emergency airway management. They can put in kind of patient demographics, doses, things like that. It lets studies be done regarding RSI, and it's a really great database. It's kind of prospective, meaning it was set up before the data is input, but this study looked at it retrospectively. They looked at it from January 2016 through December 2018. So those 3 years there, they included anyone 14 years of age or older with orotracheal intubation receiving etomidate or ketamine to facilitate intubation. They excluded anyone where the intubation was primarily facilitated by topical anesthesia, and then entries with missing data. So not just any missing data, specifically data that interacted with their endpoints. So this was if they were missing patient weight, because that's going to depend on our dosing. That's going to define our dosing, I should say. Etomidate or ketamine dose, or pre-intubation hemodynamic status. And this is going to come into play when we talk a little bit more about the sensitivity analyses that they did. The endpoints are as follows. Primarily, they looked at post-intubation hypotension. So any systolic blood pressure less than 100 millimeters mercury in the first 15 minutes following intubation. Secondarily, they looked at if this hypotension required IV fluids or vasopressor agents. They did do some descriptive statistics. So a lot of this was kind of incidence-based. Did hypotension happen? Did it not? Did they require fluids? Did it not? And then they did do some generalized linear mixed effects models that looked at a few sub-analyses where they actually associated the dose itself with increased or decreased risk of hypotension. I'd like to draw your attention to just a few of these baseline demographics. I know that this is a busy slide, but I wanted to show you that they did document the medical indication for intubation. And specifically, they looked at shock. And so I just wanted to draw your attention to the fact that this was a very low incidence of without post-intubation hypotension to with post-intubation hypotension. So this was why they did some sub-analyses of this. If you remember back when I was talking about post-intubation hypotension, shock index was a risk factor. So they included these people, and then they also did sub-analyses with them later to just kind of, because they was just like such a high risk for post-intubation hypotension with these patients. We have another one here. Again, this isn't maybe not classified as shock, or maybe that wasn't a medical indication for intubation, but they did keep track of who was hypotensive with and without vasopressors prior to intubation. And again, this is a pretty significant increase in those that were hypotensive post-intubation as well. So just keep that in mind. They did statistical analyses with these, but it is showing it here. They are included in the study. And then, of course, we looked at our sedative dose. So the mean etomidate dose was 0.28 milligram per kilogram with an interquartile range stretching over our usual dose of 0.3 milligram per kilogram. So this is what we would expect. And then the median ketamine dose was 1.33 milligrams per kilogram, again, with our interquartile range matching our dose range of 1 to 2 milligram per kilogram. This is just kind of an incidence slide. So the primary outcome of post-intubation hypotension occurred in 16.2% of etomidate receivers and 29% of ketamine receivers. And the secondary outcome occurred in 12.5% of etomidate receivers and 24.2% of ketamine. Again, this is not something that we're comparing each other to. We're not comparing etomidate and ketamine. but we are comparing what they are within different doses. So this is where our adjusted odds ratios come in. So for our primary outcome, accommodate every 0.1 milligram per kilogram dose, the adjusted odds ratio is 0.95 with a constant confidence interval stretching over 1, showing that there's no association with dose and post-intubation hypotension for etomidate in the primary outcome. For ketamine in the primary outcome, per 1 milligram per kilogram increase, the adjusted odds ratio was 0.97, and the confidence interval was 0.81 to 1.17. This also shows that there was no association with the dose. Similarly, for our secondary outcome, our adjusted odds ratio was 0.94 with a confidence interval including 1, and for ketamine, it was 0.91 with a confidence interval including 1. So all of this to say there was no association with the dose for either etomidate or ketamine for either the primary outcome or the secondary outcome for a dose increase. This is something that's really nicely graphically depicted here. So on the y-axis, the vertical axis here, we're looking at different doses of the drugs. Once again, we're not comparing the drugs, but they're separate here. So we see low doses to high doses, and then vertically we see whether they had hypotension post-intubation or not. So as you can see, the distribution of the doses across for both no and yes for post-intubation hypotension, these looked very similar for both etomidate and ketamine. You can see with the box and whisker plots there that the averages for doses and for both no and yes post-intubation hypotension were very similar there as well. So the author's conclusion is that there was no observed association between weight-based drug dose and subsequent post-intubation hypotension. I would agree with this. They did not observe any difference. I think that that is supported well by their data. There are some strengths and limitations that I want to go over. So for strengths, they did include pre-intubation hypotension. I think that it could have been natural to maybe exclude these to really look at whether the dose caused the hypotension or if it just didn't improve it. And so I'm glad they included that. I think that that provides better generalizability. They ran multiple relevant sensitivity analyses, including exclusively the patients that were in shock before, exclusively the patients that were hypotensive before, and they found no difference based on the dose in any of those sensitivity analyses. It was national multi-center database. And so in this database, providers are putting in their experiences with this. And so this is also leading to better generalizability because these are actual patients in the field or facilities that are getting this done. And I guess the national piece of it just really does add to the generalizability. For limitations, they didn't record any post-intubation sedation. So we know that post-intubation sedation, oftentimes with something like propofol, can also really impact our hypotension. And so this makes me kind of wonder whether the patients had this on board. Did they get post-intubation sedation? And if not, what's going on there, I guess, because for that 15 minutes following intubation, there's a good chance that their induction agent maybe did wear off a little bit. And if they got rocuronium, that they could have had potentially like awareness with paralysis. So there just wasn't really any data regarding the post-intubation sedation and how that might have affected their overall outcome. There was also no information on continued management. So no mortality or vasopressor use, no necessity for glucocorticoids or anything like that was shown. Again, this isn't necessarily like a comparator between the two agents, but it might have been nice to see what happened within those agents after intubation. And then there was no rationale for one agent over the other. Overall, I think that this article did a really good job of kind of showing a little bit what we already know and how we already practice. So they used doses that we already used for both etomidate and ketamine, and it basically showed that they were, in fact, mostly hemodynamically neutral. However, if you do have a practice site that changes the dose of these induction agents based on how the patient's doing, like their hemodynamic status and depicted stability, you could potentially pull out this article and show actually there was no difference between hypotension depending on the dose of fill in the blank induction agent. So that's the way that I imagine it being used. But otherwise, it kind of just showed us what we already know about etomidate and ketamine, meaning that they're both pretty good in hemodynamic instability for induction agents. In summary, the doses of induction medications are often decreased for risk of hypotension in those hemodynamically unstable patients. Data may not support lowering all doses of induction or all induction medication doses. Ketamine and etomidate have shown to have similar rates of post-intubation hypotension no matter the initial dose, especially in this article. What questions do you have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.